video is on asthma. Asthma can be defined as small airway obstruction. Let's look at the pathophysiology of asthma. So asthma is due to inflammation where an allergen activates CD4 T cells and they differentiate into Th2 cells. Th2 cells trigger B cell clonal expansion, transforming IgM antibodies into IgE antibodies because IgE antibodies are the ones involved in allergic reactions. IgE binds to mast cells with the specific information of the initial allergen, and this process is known as sensitization because the body is becoming sensitized to the allergen. In subsequent exposure, the allergen then binds to these mast cells and causes degranulation of these mast cells, which sets off an inflammatory cascade, resulting in symptoms and the pathology, which we'll look at more. Symptoms include airflow obstruction, specifically so this can be due to two factors, mainly bronchospasm or bronchoconstriction, and this is from the action of histamine, which is part of the inflammation reacting to the allergen, as well as edema. Over time, this causes remodeling of the airways as shown in this diagram. So you can broadly see the airways more narrowed, and this is due to a few factors. There's hyperplasia of goblet cells or mucus cells, so hyperplasia and hypertrophy of mucus cells, hypertrophy of smooth muscle, so the muscle becomes stronger and more strongly constricts, angiogenesis, as well as collagen deposition. And in an asthma attack, that is when this bronchospasm and the bronchiole really constricts and the air becomes trapped in the alveoli as shown in the diagram. So a patient will present with wheezing as it's really hard to push air through a narrowed airway, dyspnea, and dry cough. You may also have tachypnea and be in respiratory distress if it's a severe asthma attack. Triggers are usually related to the allergens, and some common ones are shown in this diagram, such as dust, pollen, mold, and pet dander. But other common triggers include exercise, so exercise-induced asthma, stress, having a recent cold or upper respiratory tract infection, cold weather, or smoking. Investigations, you can do a lot, but the most important one is spirometry with a less than 70% FEV1, FEVC, as shown in that diagram. And unlike COPD, this is reversible with bronchodilators. In the longer term, you can also do allergy testing to identify the allergen so the patient knows what to avoid. Management can be broken into acute and long-term. Acutely, those are your relievers, so they are bronchodilators because they open up the airway, avoiding the bronchospasm, which causes the asthma attack and the symptoms. And this is done through a beta-2 agonist such as salbutamol. Salbutamol also helps reduce edema, but important side effects include tremor, tachycardia, and cramps. Anticholinergic is another class of bronchodilators such as ipratropium bromide, with the side effects relating to its anticholinergic properties such as dry mouth, constipation, and blurred vision. So especially from the blurred vision, you shouldn't really be driving after you take them. A less common class is xanthine, such as theophylline, and they inhibit phosphodiesterase to cause bronchodilation. Preventers are what you use in the long term, such as inhaled corticosteroids, such as fluticasone. Leukotriene antagonists, such as montelukast, are especially useful in exercise-induced asthma. If you don't want to take inhaled corticosteroids because it's maybe complicated for kids to time their breathing, you can do oral corticosteroids such as prednisone. However, this is less favorable as it's more likely to get systemic side effects such as immunosuppression, easy bruising, weight gain, and in older populations, worsen diabetes as well. Monoclonal antibodies is also an emerging line of treatment. Thank you for watching. I hope you learned something. If you did, please tell a friend who may also find it useful.